Hello and welcome to another live broadcast with MedStar Health. My name is Mishan Carter, and I'm joined today by a few of our heart care specialists from MedStar Heart and Vascular Institute. Our panel includes cardiac electrophysiologist Dr. Zayd Eldadah, Dr. Cyrus Hadadi, and Dr. Glenn Meininger, who will be joining a little bit later. And also our cardiac surgeons who will join as soon as they are available, Dr. Brian Bethay and Dr. Christian Schultz. In honor of American Heart Month, we'll be talking all about arrhythmias or irregular heartbeats and the latest treatment options. While atrial fibrillation or AFib is the most common type of arrhythmia affecting millions of Americans, there are several types of arrhythmias that you should also know about. So stick around, share this live with your friends on Facebook. Give us a like to let us know that you're here and that you're watching, and share your questions with us in the comments below. We'll take some time to answer those as well. All right, so let's get started with the basics of arrhythmia. So Dr. Hadadi, what is an arrhythmia and what are some of the most common types of arrhythmias?
Of course, and Mishan, thank you so much. Welcome everyone to our discussion for American Heart Month, and we're just so thrilled and excited to be here. So, as you astutely said, an arrhythmia is the medical term for an irregular heart rhythm, and these are actually very, very common. We think that almost 1 in 3 Americans will develop the most common arrhythmia, atrial fibrillation, and that's why we're going to spend a lot of time today discussing it. But there are other arrhythmias that affect people who are very young, people in their 20s, 30s, 40s, 50s. So SVT, or supraventricular tachycardia, is a very common arrhythmia that affects young people. If you look in the textbook, it says it affects 1 in 500 people, but I think it's actually much more than that because the symptoms of arrhythmia, palpitations, a sense of unease or anxiety can often be mistaken for other medical conditions like panic attacks, for example. So many of my younger patients come to me after having gone to an emergency department more than once and being told, well, we just don't know. Maybe it's anxiety, and that's not often true. So irregular heartbeats are very, very common, and we see a lot of them in our field.
Thank you very much. It's interesting to find out that it affects even, the younger patients too. So thank you very much for explaining that. Does an arrhythmia put someone at a higher risk for other health conditions?
Absolutely. There's a very intimate relationship between the heart's electrical system and the heart's pump. And so we often joke that, we're electricians and many other cardiologists are plumbers. But arrhythmias can put you at risk of compromise in your heart function. So one flavor of SVT that affects young people is called Wolff-Parkinson-White. And it can potentially be very dangerous because if a heart that's designed to beat 60 beats a minute is suddenly beating 200 or 300 beats a minute, I think we kind of intuitively understand it's not going to do the job of pumping blood for your body. When it comes to atrial fibrillation, which I mentioned is one of the most common arrhythmias around the world and in the United States, we're really starting to understand how atrial fibrillation can compromise the strength and function of your heart, leading to a condition called heart failure. And of course, here at MedStar, we have physicians who specialize in arrhythmia, heart failure, and medical and surgical treatment of arrhythmia and heart failure. But we want to try to catch it before it gets to that point.
Absolutely. So, Dr. Hadadi, for what type of heart rhythm conditions do people need a pacemaker? When does that become necessary?
Question. So a pacemaker helps a slow and irregular heart beat at a more natural rate. So as I mentioned, a normal heart rate is about 60 to 80 beats a minute when you're at rest. And if you're significantly slower than that, it's trying to drive on I-95 at only 30 miles an hour, right? What the body is asking for is not what the heart is giving it. So you can feel tired, you can feel really winded even with minimal physical exertion. I have patients who tell me I can barely walk 10 feet. And then after I put a pacemaker in, they say, I wish I'd had that done 5 years ago, because it can be slow slow and slow and slow. And people blame their age, they blame the weather. But the reality is, if your body wants 60 beats a minute from your heart and it's only getting 30, you're not going to feel good.
I can imagine. Yeah, thanks for explaining that. Could you delve a little bit deeper and share what does a pacemaker do and briefly explain the different types of pacemakers?
Absolutely. That's a wonderful question. So a pacemaker is what we call a cardiac implantable electronic device. Believe it or not, it's a little computer, and it's probably more sophisticated than the computers that took us to the moon on the space shuttle. But what it does is it detects if a person has a slow heart rhythm, and it gently stimulates the heart to beat. So a pacemaker does not hurt. I want to be clear about that because sometimes people think that they're going to get a shock with every heartbeat, and that's not the case. And you can use a pacemaker with a microwave. You can use a pacemaker with a cell phone. So there are, a couple like urban legends that say, oh, you better not walk by a microwave or the pacemaker will stop working. And that's really not true. So I always put my patients at ease that yes, you can continue to enjoy all of your favorite microwavable meals, even though those probably aren't too healthy from other cardiac perspectives.
Right.
So we have two like flavors of pacemakers. The traditional pacemaker, which close to 200,000 Americans a year receive, was first pioneered in the 1950s. So it's an outpatient procedure that's done under moderate sedation here at MedStar Washington Hospital Center. And all of our EP doctors are pacemaker specialists. Under sedation, so that you feel totally comfortable, we'll make a very small incision here in the area of your chest, probably about 1 inch long at most. We'll make a very small space under the skin for the pacemaker combined brain and battery. And then we'll use the big vein that runs underneath your shoulder down to your heart to thread two delicate little wires, and sometimes three delicate little wires, down into the heart. Each of those wires goes to a specific space in the heart, usually the top right chamber and the bottom right chamber. So that way we have restored the rhythm of a heart that has had its electrical system break down. The other flavor of pacemaker is the leadless or wireless pacemaker. And so that is a little bit revolutionary. It's a rethink. So, just as we went from grandma's old rotary telephone to the iPhone or to the Android smartphone, the leadless pacemaker says, well, do you really need to cut the skin? And do you really need a battery under the skin? Can we put something directly inside of the heart? So for anyone who's watching and interested, this is what the leadless pacemaker looks like. It's very tiny. So it's, again, an outpatient procedure. You can go home same day or next day. It's done under gentle sedation. Here, we instead make a tiny incision in the big blood vessel of your groin and thread that pacemaker directly up inside the heart. And then we're done.
That's good to know that it's an outpatient procedure. It seems very simple for the patient to undertake and get on with living a healthy life. So thank you very
I
much.
think that we are blessed to have such a good team at MedStar Washington Hospital Center, and actually all of our MedStar hospitals, that you can come in, receive either flavor of pacemaker, and be assured that at the latest, you'll be home the next day.
That's good to know. Very good to know. One other question. I think you touched on this a little bit about how the pacemaker connects to different parts of the heart. Could you share the difference between a single chamber and a dual chamber pacemaker?
Absolutely. That's a very sophisticated question. And what that is asking is, where in the heart does the pacemaker go? So in general, you can put a pacemaker in the top right chamber or the bottom right chamber, depending on a person's needs. Most people, about 80% of people, would benefit from a pacemaker that can pace the top chamber. And so dual chamber pacemakers with both wires are what we more commonly use. And the nice thing about MedStar, and for the time being, really only MedStar, because we have such a sophisticated program, is that we have dual chamber traditional transvenous wired pacers, and we have dual chamber leadless pacemakers also. So when you come and talk to your doctor, we really want to have a good, careful discussion and share you in the decision-making process. We want you to help us decide what the best pacemaker for you is. Again, resting assured in the knowledge that you're going to have a good, safe, effective procedure.
Thank you very much for explaining that. Uh, to sort of tie into that, when is a leadless pacemaker recommended over the traditional type of pacemaker?
I think that's a wonderful question. And I would say, in general, talk to your doctor about what type of pacemaker you're interested in and the benefits and the disadvantages therein. I think each type of pacemaker is a very sophisticated device that has a perfect patient profile. So if you start with recognizing that there may be symptoms of a slow heart rhythm, like, again, fatigue, tiredness, inability to do the physical things you're used to, like chasing your grandkids around or going for a walk with your loved ones, you might be a candidate for a pacemaker. And from there, talk to your doctor about what you want.
Great. Thank you very much, Dr. Hadadi. I'd like to welcome one of our electrophysiologists, Dr. Glenn Meininger. Thank you so much for joining us today as well.
Thanks for having me. I appreciate it.
Thank you. At this time, I'd like to talk about defibrillators. So turning to Dr. Eldadah, could you share what is an implantable cardioverter defibrillator? When is it needed? Where does it go? It's a complicated term, but could you explain it for us?
Absolutely. Thank you, Mishan. So we just heard a very nice conversation and discussion about pacemakers by Dr. Hadadi. And the traditional pacemaker, again, looks like this, a small device that historically has been implanted under the collarbone, and Dr. Hadadi walked us through leadless pacemakers. Defibrillators, or ICDs, ICD stands for implantable cardioverter defibrillator, is a pacemaker, all the circuitry, all the capability of a pacemaker that can keep the heart pacing, plus the plus actually in a defibrillator is a little bit more battery, a little bit more computer capability, a little bit more size, and one major important functional difference in that a defibrillator, in addition to doing everything a pacemaker can do, also has the ability to watch over the heart 24 hours a day as a, if you will, guardian angel. And should the heart develop a sudden, life-threatening heart rhythm disorder, typically known as ventricular tachycardia or ventricular fibrillation, when the normal rhythmic contractions of the heart get hijacked and suddenly the heart's bottom chambers start quivering, that can be life-threatening. It can lead to sudden loss of blood pressure and even death. The defibrillator can recognize that and treat it by applying either very rapid pacing to the heart, which can reset the heart and restore normal rhythm, or by actually delivering a shock to the heart and restoring normal heart rhythm that way. So defibrillators can be life-saving, and they've revolutionized the care of patients who are at risk for life-threatening heart rhythms, and they save lives every single year.
That's amazing. Could you let's talk a little bit more about AFib. Could you share what is atrial fibrillation, also known as AFib? Why is it so common?
Of course. So atrial fibrillation is the most common heart rhythm condition, or most common heart rhythm variation disorder. I'm going to avoid using the word disease, and just for a reason that I'll explain in just a second. The most common heart rhythm disorder seen in human adults. The lifetime risk, as Dr. Hadadi mentioned, in human beings is about 1 in 3. So about a third of all human beings alive today either have atrial fibrillation or will have atrial fibrillation over the course of a typical lifetime. Let's just go through what atrial fibrillation means by contrasting it with normal heart rhythm. This is just a model showing a normal human heart. And if we open up the heart, we'll notice that the heart consists of 2 upper chambers and 2 lower chambers. And the way the heart works, it's this beautiful organ that pumps blood through our body. blood enters the upper chambers. They fill with that blood, then squeeze the blood into the lower chambers, which subsequently fill with the blood, and then squeeze the blood out of the heart to expel it to the body, to the lungs, to keep the circulation going. That process of squeezing is under very tight, elegant electrical control. When the electricity travels through the heart in an organized way, the heart pumps in an organized way. In atrial fibrillation, what happens is that organization gets hijacked. The upper chambers, instead of beating in an organized, rhythmic, regular way, are actually not beating at all when they get taken over by atrial fibrillation and begin to quiver chaotically, like a bag of worms. So the muscle tissue isn't able to squeeze blood, but rather it just quivers, and blood makes its way through the heart through the squeezing action of the bottom chambers. The upper chambers in atrial fibrillation just quiver without squeezing. The bottom chambers, because they receive their electrical instructions from the upper chambers, suddenly see chaotic electricity, and they will squeeze, but in an erratic, often rapid, irregular way. That's what atrial fibrillation looks like. So it's a really profound change in the way the heart squeezes. Atrial fibrillation in and of itself doesn't cause death. It's not immediately life-threatening, but it can create significant symptoms. And it can, in the long run, actually cause an increase in the risk of the most dangerous consequence of atrial fibrillation, which is stroke. When the upper chambers of the heart aren't squeezing properly, there can be an increased risk that blood will pool and settle in those upper chambers and potentially form a blood clot. And a blood clot in the heart can be particularly dangerous because if it gets expelled into the body, it can block blood flow, most significantly blood flow in the head. So if there's inadequate blood flow because a blood vessel is blocked by a blood clot, that can lead to a stroke. Stroke means death of brain tissue. So the single biggest health concern in atrial fibrillation is risk of stroke. So if you or any member of your family has been told that you have atrial fibrillation, the first question or the first conversation with your physician should be, what is my risk of stroke and what are we doing to minimize that risk? And we have some very good therapies, very good methods of reducing risk. The reason, to answer your question, that atrial fibrillation is so common is a very simple one. It's because we as humans continue to age. Atrial fibrillation, we're recognizing, is probably not fair to be called a disease because it's so tied to the human aging process, mimicking the way we develop gray hair, typically over the course of time, typically later in life. Atrial fibrillation follows the same general pattern. And just like not everybody develops gray hair at the same time in life, not everybody develops AFib at the same time. There are many other factors that influence atrial fibrillation, like genetics, like other bodily conditions. And keep in mind that 2/3 of humans probably don't develop any atrial fibrillation at all in their lifetimes, not because they're magically immune to the AFib. It's probably more the case that they're developing it, it's brewing inside them. It just isn't on track to manifest until maybe outside a typical human life, at age 120, age 140. If people continue to live longer and longer, though, we're going to see more and more atrial fibrillation as a result. So aging is the primary reason that people develop atrial fibrillation.
Thank you very much. Speaking of AFib, continuing with that, could you share what are the symptoms? How is it diagnosed? Could someone have arrhythmia and not have any symptoms at all? What should we be looking out for?
Great question. Yes, so atrial fibrillation we've just reviewed is a type of arrhythmia. Arrhythmia means abnormal heart rhythm. Atrial fibrillation is the most common type of abnormal heart rhythm seen in human adults. And how it presents can be very variable. A simple take-home message is that atrial fibrillation doesn't follow a single script or a single screenplay in all people. The ways atrial fibrillation presents are almost as numerous, it could be said, or as numerous as the people in whom it presents. So it can be very variable. In general, atrial fibrillation consists of an irregularity in the way the heart beats. Sometimes the irregularity can be rapidly irregular, sometimes very slow but irregular. But that irregularity in some people can cause symptoms. Because what happens is when the heart rate is irregular, the heart no longer pumps efficiently. So the kinds of symptoms people develop are the symptoms of a heart that becomes suddenly less efficient. Sometimes when I talk to patients, I ask them to think about your car engine when it's humming smoothly. That would be like normal rhythm. And if the engine starts knocking, that's like atrial fibrillation. You might be aware of it, you might hear some funny sensations. The car may not be so good at climbing hills, etc. You can still get around, you can still drive. It's just not a very effective drive, not a very robust one. That's how atrial fibrillation can sometimes present. So it can lead to palpitations, feeling like a fish is flopping around your chest, feelings of very rapid heart racing. It can be associated with dizziness or lightheadedness or fatigue or shortness of breath. But very interestingly, it can also be associated with none of those things. It can be possible for atrial fibrillation to be happening and for a patient or for an individual not to be aware of the atrial fibrillation at all. In fact, to be conducting life normally. I have a very classic patient who was discovered to have had atrial fibrillation nonstop for the previous 20 years. And not only was he normal, but he was at age 74 swimming across the Chesapeake Bay every spring, completely unaware that he had anything wrong with him. That's an exception to the rule, but it highlights the fact that atrial fibrillation can be very variable. On the flip side, there are some people who have enormously profound symptoms and are very miserable, and that heightens the imperative for us to relieve those symptoms. But in all people, whether they have symptoms or not, atrial fibrillation does need to be addressed, primarily because of the increased risk of stroke. And that increase in risk progresses over time. Also important to note, atrial fibrillation typically gets more and more pronounced over time. It often will start with occasional episodes that may or may not even be noticeable, and if left completely unaddressed, may progress to being present all of the time. So atrial fibrillation is a very common condition. It's not always easy to recognize because it doesn't always follow the same set of patterns. And the diagnosis of it is typically made by an electrical measurement of the heart, most classically in a doctor's office by getting a formal EKG, which is an electrocardiogram, an electrical assessment of heart function. But nowadays, with more modern and widespread technologies, atrial fibrillation can often be quite effectively picked up by an Apple Watch or equivalent, one of these electrical watches that can pick up heart rhythm, or some of these phone algorithms that involve placing your fingers on the back of the phone. Not as accurate or sensitive as an EKG, but not bad either as a screening tool.
Very interesting. Thank you very much. So you mentioned how AFib can put you at a higher risk for stroke. Are there any other health conditions that that AFib can put someone at a higher risk for those conditions?
It's a great question. So when we talk about atrial fibrillation, we don't want to create a sense of panic or worry or fear every time that maybe your heartbeat is a little irregular. We don't need to panic or worry. And keep in mind, too, that even full-blown atrial fibrillation in and of itself is not an acutely dangerous condition in general, but it just requires attention. Atrial fibrillation becomes increasingly likely as we're growing older. So it's important that as we progress through life, particularly in our later years after 60 and 70, we have regular contact with a physician so that a yearly EKG can be done. Investigation of the heart can be done in a screening way that meets current guidelines to pick it up. And of course, if there are any symptoms, we want to make sure that they're addressed. And the reason is first and foremost because the risk of stroke in atrial fibrillation in general is about 5 times greater than the risk of stroke in people without atrial fibrillation. But atrial fibrillation can also contribute to other conditions that are not good. In a simple word, the presence of atrial fibrillation makes the aging process worse than it would be without atrial fibrillation. Aging is challenging enough on its own, but when you couple it with atrial fibrillation, things don't go as smoothly as they could. So there is an imperative to try to recognize atrial fibrillation, and we have very good tools nowadays to actually suppress it and reduce it, and that's going to be part of our discussion in a little bit. But simply put, atrial fibrillation can contribute to worsening heart squeeze function, the symptoms of a worsened heart pump. It can contribute to true, what we call heart failure, when the muscle tissue of the heart is weaker than normal. It can contribute to the heart structurally dilating, getting more enlarged, and that can pull heart valves apart, lead to their being leaky. It can sometimes promote actual damage to heart muscle tissue, what we commonly call a heart attack, if a patient already has heart blockages in the arteries feeding the heart, and suddenly the atrial fibrillation contributes to very rapid heart rates. So there are a number of downstream consequences of atrial fibrillation that are adverse. They're not in our best interest. So we should be vigilant for atrial fibrillation, recognize it, and do our best to suppress it and treat it whenever we can.
Great advice. Thank you very much, Dr. Eldadah. At this time, I'd like to pause and welcome our viewers again. If you're just joining us, thank you for tuning in. We're talking all about arrhythmias or irregular heartbeats and the latest treatment options. February is American Heart Month, so it's the perfect time to speak with a few of our heart care specialists here. I'm joined today by cardiac electrophysiologist, Dr. Zayd Eldadah, Dr. Cyrus Hadadi, and Dr. Glenn Meininger. We also have our cardiac surgeon. We're hoping that he will be able to join a little bit later with us. He's seeing patients. His name is Dr. Christian Schultz. So we look forward to speaking with him as well. We have more to talk about, so keep watching, give us a like, share your questions in the comment section below. At this time, I have a few questions from our audience. Thank you all for tuning in and sharing these with us. The first question I have is from D Wolf. They're asking, can you address pulmonary hypertension and AFib in regards to an ablation or inserting a pacemaker?
Hi, Dee. Well, I'll handle the pacemaker portion of things.
Okay.
So pulmonary hypertension is well known in our community. And again, at MedStar, we have a wonderful team of pulmonary hypertension specialists. So for people on Facebook who are watching at home, I think the easiest way to understand pulmonary hypertension is when we talk about high blood pressure or hypertension, we're usually talking about high blood pressure in the blood vessels of our body, arms, legs, brain. But pulmonary hypertension is a special kind of high blood pressure that affects the blood vessels inside the lungs. So pulmonary, lungs, hypertension, high blood pressure. We often see patients with pulmonary hypertension here at MedStar. However, pulmonary hypertension can be a delicate situation that requires a really specialized team of anesthesiologists to help manage you during a procedure. So the short answer is yes, we've done many successful procedures on patients who have pulmonary hypertension, but you really need a wonderful team of anesthesiologists to support your cardiologists and your surgeons. And we have that at MedStar. I don't know if Dr. Eldadah or Dr. Meininger want to comment on the atrial fibrillation portion of the question.
So we can just say a couple of words. In pulmonary hypertension, what often happens is there's back pressure that can lead to stretching of the upper chambers of the heart, and that can contribute to making atrial fibrillation more common. Pulmonary hypertension, as Dr. Hadadi mentioned, makes treatment of anything else a little more complicated and does require a little more specialized attention and expertise. So if pulmonary hypertension is present and atrial fibrillation is present, we'd advise you to seek out care in a center that has very good experience in both conditions because they can present at the same time. And they just require a little more work to be managed effectively.
All right, thank you very much. We have another question this one is from Kim Seelover, who's asking, how often does the battery in a pacemaker need to be changed?
Hi, Kim. That's a fantastic question. And of course, it's a very pertinent one. All of our patients sometimes feel like the $1 million woman who had all these parts. So the batteries are designed to be as sophisticated and long-lasting as possible. Believe it or not, back in the 1950s, for a while, we actually had pacemakers with a uranium chip inside. So they were nuclear powered and would last basically forever. But nowadays, we use very sophisticated lithium batteries. And I would say, in general, it's reasonable to expect anywhere from 8 to 10 to 12 years of battery life on your pacemaker. Now, a pacemaker that's not used very frequently, one that's a backup for people who, for example, might have rare fainting episodes or syncope due to slow heart rates, could last up to 20 years because it's not being used as much as others that are pacing the heart more often.
All right, thank you very much, Dr. Hadadi. I have another question. This is from Karen. They're saying, I got a pacemaker last July and have a machine that each month gives us a report of the number of AFib symptoms, I believe, mostly at night, but I can't feel anything. My cardiologist suggests getting the Watchman. Can you give us some information about the Watchman? We have a few audience members who also have questions about that.
Sure. So I think that's a two-part question, really.
Okay.
So the first is, with modern pacemakers, we have the ability to check them wirelessly and send reports to your physicians, which is absolutely wonderful. I feel like it's almost cheating to know what's going on inside my patient's heart, especially at night when they may not necessarily feel the symptoms that you might during the day. As Dr. Eldadah mentioned, one of the challenges with atrial fibrillation is that it is so common. Again, almost 1 in 3 people. So I'm a little hesitant because I count Dr. Zayd Eldadah, Dr. Cyrus Hadadi, and Dr. Glenn Meininger. So if we play the dice, one of us will develop atrial fibrillation. But many people who have atrial fibrillation don't know that they have it. If you have atrial fibrillation, you have a 5 times higher risk of a stroke than somebody who doesn't, who otherwise is identical to you. So it's helpful for us to be able to check pacemakers from the comfort of your own home. If we find that you have atrial fibrillation and that you're at a higher risk of a stroke, well, for many years, we've been managing that risk of a stroke with blood thinners. But not every patient is a good candidate to be on blood thinners long term. Some people have lifestyle challenges. If you are a hunter, a fisherman, a waterman, like many of my patients from the Eastern Shore, you don't want to be at risk of excessive bleeding if you accidentally cut yourself on an oyster shell, for example. Or, a patient who's very vigorous, very active, biking 50 miles on the weekends, you don't want to fall off your bike and then be at significant risk. Other people have medical reasons not to be on blood thinners. You might accidentally bleed, God forbid, into your stomach or your intestines and have anemia, and that's only found out after a visit to the hospital. So the Watchman is a very, very clever and sophisticated device. It's in a class of devices called left atrial appendage occlusion devices, and that's a mouthful. But when we think about the heart, and I don't know, Dr. Eldadah, can you show us on your model, inside the top left chamber of your heart, the left atrium, there's a little pouch called the left atrial appendage. And it seems to be the source of up to 90% of the blood clots that cause strokes in atrial fibrillation. So a medical cardiac electrophysiologist like Dr. Eldadah or Dr. Meininger or myself can percutaneously close off this pouch to try to minimize the risk of a stroke, and then our patients don't need to be on blood thinners. A surgical cardiologist like Dr. Schultz or Dr. Bethea can clip or snip this appendage and then again minimize the risk of a stroke. So Dr. Eldadah is showing us the model of the Watchman. It's folded up like a tiny little umbrella. And during, again, an outpatient procedure, we can percutaneously go up from the blood vessel in the groin, drop it off inside the heart, and our patients can go home same day or more often next day, resting assured that as the Watchman heals into the heart incorporates it. That doesn't happen in real life, Dr. Eldadah. To close off this pouch and minimize your risk of a stroke. So to answer the question a little bit more thoroughly, if we find on your pacemaker or pacemaker defibrillator that you're having episodes of atrial fibrillation that you didn't know about, it's worth a conversation with your doctor to see if you're a candidate for a Watchman to reduce your risk of a stroke.
Thank you very much. I appreciate the visuals. I think that helps give our audience a better picture of the types of treatments that are available, what's going on actually inside of the body. I like that it's, a lot of these procedures are outpatient and, we can accommodate patients' busy lives and help them get back on track. So thank you very much. At this time, I'd like to turn to Dr. Meininger. Let's talk a little bit more about AFib. Could you share, are there different types of atrial fibrillation?
Yeah, so I think commonly when we're thinking about atrial fibrillation, we're generally speaking of people that either have it intermittently or something we call paroxysmal atrial fibrillation. Some people have it more persistently, where these episodes not only are, minutes to hours in duration, but can actually be days or weeks long. And then there are people that Dr. Eldadah was referring to earlier that are chronically in atrial fibrillation. And it's important to understand in which category you fall in because it has implications for how we address treating it. People tend to be better identified earlier when they're having paroxysms of atrial fibrillation because the treatment options tend to be more successful. So, but typically when we are in broad strokes trying to define people as having atrial fibrillation, we're trying to understand which of these classes they sit in.
And that sort of leads to my next question. Could you share the different treatment options available for AFib?
Sure. So atrial fibrillation, I mean, the beautiful thing is that all three of us have kind of watched the evolution of the management of atrial fibrillation over the last several decades. And it went from a rhythm that was really managed just with medications to slow the pulse rate or consideration of a pacemaker to speed up the pulse rate. But we now have a whole breadth of options in terms of treating arrhythmia. Firstly, we have a better understanding of some of the drivers for what causes atrial fibrillation. There are many things that are part of our makeup. Do we have high blood pressure? Obesity can be an influencing factor. Sleep apnea. But also there are lifestyle components that we have a better understanding as well. We do know that alcohol, dehydration can be, big factors in influencing occurrence or recurrence of arrhythmia. So I think in general, our first focus is really to look at some of these lifestyle pieces that we can address. And certainly I think many patients with atrial fibrillation kind of independently think through what leads to my episodes of atrial fibrillation, especially if they're symptomatic. And they often come to us with some understanding that there are certain drivers that seem to set off their arrhythmia. But once we've kind of looked at the lifestyle pieces, then it's really thinking about medication strategies to manage arrhythmia. And there are kind of broadly, I would list two types of medications. Now, this is beyond treatment of stroke risk. So anticoagulants or left atrial appendage occlusion devices are really aiming to address our primary concern, which is stroke risk. But now kind of switching over to what medicines do we use to actually manage the episodes themselves. The two classes we tend to use, one are called AV nodal blockers, which are medicines that are aimed to kind of slow the heart rate. And these are aimed at people with very rapid atrial fibrillation. These medicines fall into a class of drugs called either beta blockers, calcium channel blockers, or less often digoxin, which can be used for rate control. Really in an effort to try and avoid symptoms or complications associated with very rapid atrial fibrillation. The second group of medicines we use are what we call antiarrhythmic drugs, and they are drugs that are aimed to have an impact on either preventing AFib from developing in the first place or to try and quickly restore normal rhythm. These antiarrhythmic drugs have properties that slow conduction through muscle to muscle. They work on various channels within the muscles of the heart to affect restoration of normal rhythm. And there is a whole group of antiarrhythmic drugs. Newer ones are being developed occasionally, which can be used to help manage and maintain normal rhythm. So it's often looking at a patient, trying to understand the mechanism of their AFib, but then it's often us working through choosing the right medications to try and help regulate the rhythm.
Right. Thank you very much, Dr. Meininger. Turning to Dr. Eldadah, I think we sort of mentioned this a little bit earlier, but for people who may have joined a little bit later, could you share what is longstanding persistent AFib and how is that different from the conventional type of AFib?
Of course, thank you. So Dr. Meininger very nicely laid out the progression of atrial fibrillation. So let's just remember that atrial fibrillation is in general an aging-driven phenomenon. So if we can think of it, maybe we can think of an example. Think of the example of firewood, and let's call firewood's ignition, catching on fire, an episode of atrial fibrillation. What do you need to get firewood on fire? Well, you need the firewood itself, and you need a match or something to trigger the fire. Atrial fibrillation can be thought of, or the likelihood of atrial fibrillation can be thought of as the deposition of flammable firewood over the course of time. As we age, all of us are more likely to get this firewood. There are things that accelerate the presence of firewood, like having high blood pressure, being overweight, not exercising, not taking care of oneself, abusing our bodies. That can lead to more firewood earlier in time. And then, as Dr. Meininger was alluding to, the actual episodes of atrial fibrillation happen when some sort of match gets struck and ignites the fire, ignites the firewood that's there. If somebody doesn't have the firewood, you can have all the match strikes you want, there won't be any fire. Similarly, if the firewood is just depositing but nothing triggers it, there may not be atrial fibrillation. What we're getting at is that there are triggers in life that can stimulate the fire in the presence of that predisposition or the firewood. And Dr. Meininger was mentioning triggers can be numerous in life. It can be exhaustion, it can be alcohol intoxication, it can be an upper respiratory infection. So many triggers can lead to these episodes, but it's the presence of that predisposition that's driven by aging and genetics and other conditions that leads to the AFib. And as mentioned, AFib typically starts off as episodic, here and there, like many phenomena in biology or in nature. How do weeds start in your garden? They start off with a weed here, dandelions here and there. And if you leave things alone, what happens? More and more develop. And if you completely neglect the weeds, the whole lawn will get taken over and there'll be nothing but weeds, no normal lawn. So in atrial fibrillation, it's simple. The occasional intermittent episodes are known as paroxysmal AFib, the weeds here and there. Persistent atrial fibrillation is more than that. Specifically, it's atrial fibrillation in which the episode lasts at least a week, but less than a year, and something needs to be done to restore normal rhythm. Long-standing persistent atrial fibrillation is the next category. It's when the lawn has really been taken over by weeds. We define it medically as atrial fibrillation that has been continuous for at least a year. That's defined as long-standing persistent AFib. And the reason that it's significant is because the more atrial fibrillation develops, the more atrial fibrillation will develop thereafter. Atrial fibrillation leads to more atrial fibrillation, just like some weeds will lead to more and more and more. And the heart, what happens is when the upper chambers are quivering and fibrillating, they end up stretching and contorting and becoming dysfunctional. And that in turn leads to more atrial fibrillation, which leads to more mechanical dysfunction. So it's a vicious cycle. That's why the final pathway that atrial fibrillation leads to, if it's left untreated, is long-standing persistent atrial fibrillation. So if you look at all the cases of atrial fibrillation out there, almost half of them are actually in that category. And that category keeps getting bigger and bigger and bigger because people are entering it every day, innumerably. That's what long-standing atrial fibrillation is. Atrial fibrillation that's present all the time. How do we treat it? Well, the treatment for atrial fibrillation, the way that we address it is very similar in all categories, but more intense as we get more advanced. So the more atrial fibrillation has been around, the more it has had impact on the heart, the tougher it is to dislodge. What's the analogy there? It's a lot easier to treat weeds in your garden when they're just here and there. You can spray them. But when the whole garden's been taken over, it takes a lot more work. Similarly, it takes more work. So in long-standing persistent AFib, we always have the imperative to make sure the patient's risk of stroke is minimized. So the first question on anybody's minds, anyone who's been diagnosed or suspected to have atrial fibrillation, is what is my risk of stroke and what am I doing to minimize risk? Once that's been addressed, next comes, what am I doing to make sure that atrial fibrillation is not causing my heart rate to be too rapid? Dr. Meininger nicely outlined, we want to make sure the heart rate is a little slower, slowed down, so the bottom chambers, the ventricles, don't beat so rapidly. Then comes the key question, what am I doing to suppress the AFib altogether? Because I know that atrial fibrillation is not healthy. It's better that I stay in the rhythm I was born in, the normal rhythm. What can I do to achieve that? And there are medicines that do it. There are catheter-based procedures that can do it. However, in long-standing atrial fibrillation, long-standing persistent atrial fibrillation, sometimes the muscle changes are so profound that medicines alone or a simple catheter procedure alone is probably going to be insufficient. And that's why the FDA approved a novel therapy as a first-line approach for people with that end stage or more advanced stage of atrial fibrillation. And that's what we're going to talk about shortly.
All right, I think that's a great segue to my next question for Dr. Meininger about hybrid AF convergent therapy. I hear that it's the first FDA-approved treatment for patients who have that long-standing persistent AFib. Could you share what types of physicians perform that procedure? What happens during the cardiac surgery procedure? Could you elaborate a little bit more about that?
Sure. Yeah, I'm happy to talk about it, and it's kind of, we're in a unique position, unique location. I hope Schultz is able to join us, Dr. Christian Schultz, because, he has really been one of the kind of stalwarts getting this started at MedStar. And, essentially what hybrid ablation is, it is a procedure that's targeting this group of longstanding persistent atrial fibrillation. And we do it by way of a traditional AFib ablation, which involves targeting the dominant drivers for atrial fibrillation in many patients coming from within the pulmonary veins, but also targeting an area of the posterior wall, the back wall of the left atrium. Those two areas seem to be a prominent driver and trigger. The way the procedure is done varies a little bit. The way we traditionally will do it as a staged procedure, it involves two physicians. We use a cardiothoracic surgeon and an electrophysiologist. And the first portion of the procedure involves a small incision made underneath the xiphoid, which is right at the base of the sternum. It's done under general anesthesia. They put a small catheter into the sac around the heart, and they will actually ablate using a catheter. And what ablate means is that they will heat the muscular tissue of the back wall of the atrium and create scar. Now, I think when people hear scar in their body, they don't necessarily think of that as a good thing, but the scar is really in an effort to target the triggering areas that are setting off atrial fibrillation. So the scar is a necessary treatment in order to target or eliminate the areas of the driving arrhythmia. That's stage one, often taking about an hour and a half to do, to 2 hours. Then typically we will bring them back at a later time, either the following day or same day, or at some point in the future. And we will do our traditional catheter-based procedure where we access veins in the leg with IVs. Through those IVs, we put catheters up into the heart, and we will look at the ablation that was performed by the cardiothoracic surgeon. We will make sure that they have completely ablated or scarred the posterior wall, and then we will isolate the traditional area of the pulmonary veins. The combination of the procedure has been shown to have notable advantages in terms of maintaining normal rhythm in this group of patients that we once thought really had very low likelihood of being able to restore normal rhythm. There are some other things that we do associated with that procedure to try and help minimize risk. And on occasion, we will also what we call ligate or clip the left atrial appendage or ablate an area called the cavo-tricuspid annulus to ablate atrial flutter as well. So this is a much more involved procedure, but one that offers a potential advantage for people with longstanding persistent atrial fibrillation. Again, these patients really had no options in the past because the atria were so dilated, they were so advanced in their disease, that we are very happy to be able to offer the ability to treat these patients.
Thank you very much, Dr. Meininger. I'd like to turn back to Dr. Eldadah, talking more about this procedure. Is it widely available? Do certain hospitals or health systems offer this now? And how long is the typical hospital stay after the procedure?
Great, thank you, Mishan. Yes, so convergent atrial fibrillation ablation, as Dr. Meininger so nicely explained, is an enhancement. It's another step forward in our understanding of how to push back on this phenomenon of atrial fibrillation. So if you think of AFib as an aging-related progressive process, it's a biologic process. It's not a disease. It's not a tumor that can be cut out of the body. It's not an infection that can be treated with antibiotics, for instance. It's actually an ongoing biologic process that involves changes to the tissue of the heart. So our technology has evolved to meet change with additional change to push back on it. And convergent ablation is one of those major steps forward. We actually, MedStar Health was the first health system in the region to introduce this therapy back in 2011. So it's been done for quite some time. There's been a lot of accumulated experience, and Dr. Schultz is one of the country's experts in this technology on the surgical side, because it involves a very nice convergence of two specialties, cardiac surgeons and cardiac electrophysiologists, and it involves a very nice convergence of approaches to the heart, the inside out by the cardiac electrophysiologist, the catheter doctors, and from the outside in done by the cardiac surgeons. And in so doing, we can achieve a very effective way to block atrial fibrillation signals from having their effects. It has been FDA approved as first-line therapy for people with very advanced AFib, AFib that has been largely untreated and is present for a year constantly or more, longstanding AFib. In some cases, though, we also turn to convergent atrial fibrillation ablation in patients that have other forms of AFib, but in whom the other therapies for AFib were ineffective. If catheter ablation was tried a couple of times and ineffective, that patient may be a candidate for convergent AFib. So if you will, it's the best next step that maximizes effectiveness by adding a little more invasiveness, but less invasiveness than a full-fledged surgery. There's an entire field of opening the chest to treat atrial fibrillation, which we're not going to talk about now. So getting around to your question, do all centers offer this? No, because the expertise involved really requires a surgeon to do this in a dedicated way and have continuous practice to do it well. So there are a handful of centers around the region and around the country that have developed this expertise. Not everywhere, but certainly talk with your doctor. Your doctor will know, hopefully, or be able to find out by asking the region who would be or what facility would be best to do this procedure when it's indicated.
Thank you very much. One other question regarding the safety of the procedure. What are the risks involved and what considerations are made when evaluating a patient for this procedure?
So it's a good question. So, as medicine is evolving, some things are becoming less invasive, less intrusive, being done sometimes without even touching the patient altogether. For instance, there's an entire field of shrinking tumors and removing them without doing any surgery, without touching the patient, by applying energy from outside the body targeted. And I use that as an example because the field of ablation therapy may be headed in that direction too. One day we'll be able to do these therapies without touching the patient, without using a catheter, without making an incision. But for now, cardiac procedures to suppress atrial fibrillation require touching the heart, either with a catheter or by incising the body, entering and touching the heart from the outside. So the more invasiveness one is subject to, the more likely there can be complications. So the more invasive a procedure, the higher risk it is. We still consider convergent atrial fibrillation ablation to be a minimally invasive procedure because the incisions are tiny that the surgeon makes, and the work the surgeon does is relatively simple. It's not very complicated. There's not a lot of suturing or cutting. There's a straightforward protocol, but there's more risk than a simple catheter procedure. So risks have to be shared with patients. There always can be a risk of bleeding or injury to blood vessels, injury to the body itself, anesthesia-related complications, need for additional surgery. Every procedure can carry risk, and the decision to proceed with a procedure, like anything, should be made after a careful assessment of risks and benefits. When the risks of a procedure are very outweighed by its benefits, it's preferable to do the procedure, and it would be indicated, and it's the right thing to do. If the risks of the procedure outweigh the benefits because a patient might be particularly frail or have lots of other medical conditions making such a procedure not a good choice, then of course it's better not to do that procedure. And that's the kind of decision making that's done face to face with the physician and the patient and the family, so that the patient's best interest is always pursued, and safety is always number one and on our priority list.
Absolutely, I agree. That's very important. Thank you very much, Dr. Eldadah. As we close our Facebook Live, I'd like to ask the entire group what research or clinical trials are being conducted at this time, or anything on the horizon to address heart rhythm disorders.
Well, I think the most interesting research that's coming out is twofold. As Dr. Eldadah and Dr. Meininger have mentioned, atrial fibrillation itself can cause problems, and there's the risk of stroke. So at MedStar, we're actively investigating both of these concerns. When it comes to atrial fibrillation itself, we've talked about ablation, how to silence the irregular rhythms. So 10 years ago, we used heat energy. Now I think we preferentially use freezing cold energy. And in the next year or so at MedStar, we're going to investigate a completely different type of energy called pulsed field. So pulsed field energy seems to be as effective or more so than the alternatives, but allows us to offer ablation therapy to more patients while still being an outpatient, in and out, same day or next day procedure. When it comes to protecting against stroke, we continue to work with now the third generation of the Watchman device, trying to investigate, can this Watchman device and just a tiny daily baby aspirin replace a full dose blood thinner, but keep you safe against stroke? Those are two projects that I personally am very interested in. I don't know if Dr. Eldadah or Meininger are aware of other really interesting research projects to share.
Absolutely.
Yeah,
So
no,
better therapies as we go along, and less invasive therapies, less touching, but more effectiveness. So harnessing the power, for instance, of gamma knife technology and further advances as we progress over time. Sorry, Glenn.
No, I sort of, I think really that those are the areas where most of the movement is going. One is trying to protect against stroke risk and really looking at how we're selecting patients for left atrial appendage closure devices and what medications we can use around the time of those being placed. And then we're always looking to evolve the procedure of atrial fibrillation ablation. And pulse field is no question a real interesting technology that's going to have a major impact on the field of arrhythmia.
Well, thank you very much. I really appreciate all of this information. I definitely learned a lot. So thank you very much for spending time with us. That wraps up our Facebook Live for today. I'd like to thank Dr. Eldadah, Dr. Hadadi, and Dr. Meininger for spending time with us. And thanks to all of our viewers for tuning in, sharing your questions. We'll make sure that we'll share those other questions that we weren't able to address during the Facebook Live. We'll take them offline and have our panel of experts answer those for you as well. If you have any more questions, please share them with us below in the comments. For more information or to schedule an appointment with our heart care team, please visit the link in the comment section. We'll share that with you shortly. Thanks again, and everyone have a great day.
Thanks,
you.
Mashan.
Happy
Thank you.
Valentine's.
Happy Valentine's Day.
Happy Valentine's Day. Take care.